So I will be approaching tinnitus now from a very practical approach. What can you as a healthcare provider use as knowledge in order to try and help people with tinnitus? Even though the pathophysiology is not completely unraveled yet, there is some information that we can use in order to try and develop new treatments for tinnitus. It's a common problem, seems to be somewhat more predominant in males than in females. There is a difference in lateralization of the tinnitus perception, and it is more common in patients with hearing loss. Now, many people with tinnitus can perfectly well live with it, but a small population, about 20% of those who have it really suffer from it. And whether you suffer on it from not or not has not a lot to do with a lot of things that you can control, but the way your brain is wired. Also, with age, with increasing age, there is an increasing prevalence of tinnitus. For war veterans, actually it's the most important or the most prevalent problem of all the problems that war veterans have when they come back, and also more and more young people who expose themselves to noise because of leisure purposes do tend to develop tinnitus. Grossly, you can subdivide it in pulsatile tinnitus or in non-pulsatile tinnitus. This is just a practical division. You can also talk about objective and non-objective tinnitus. I will predominantly talk about non-pulsatile subjective tinnitus. The way we try when we see somebody in the clinic to look at tinnitus is that we do a certain amount of standard testing basically to analyze the tinnitus. So you can do tinnitus matching, where you present tones and see whether they match what the patient perceives, both in pitch or in frequency and in loudness. And then you also look at how much the tinnitus interferes with the personal life, how distressing it is, how it interferes with their mood, and you do that by standardized questionnaires. Now, because tinnitus is most commonly related to a hearing problem, of course you also have to analyze the function of the auditory system, which is done by ENTs and audiologists by doing a clinical exam, doing audiometry, tympanometry, and sometimes brainstem evoked potentials or autoacoustic emissions. And then, after you've looked at the function, you also want to look at the structure of the extended auditory system, not just the auditory system itself, because we know there's also a lot of non-auditory brain areas involved, and this you most commonly do with an MRI or with a CT scan. And then ultimately, what we want to get to in the future is that we have a way to objectivate the tinnitus, so that without anybody telling us, by doing testing, we can tell whether somebody has tinnitus or not, and secondly, whether that tinnitus is bothersome and how loud it is. This could theoretically be done by fMRI, but also in an easier way by EEGs. And together with Marco Congedo from the INSERN in France, we're trying now, and with Sven's help, to use a multidimensional classifier, which is actually up to now in the first testing that we've done extremely good in telling whether somebody has tinnitus or not, but whether it is distressing or not is not very well predicted just from the activity of the EEG. So in the future, that will advance to a level where we'll have something that can objectivate the tinnitus. Now, it's important to know that that deafferentation, so a lack of sensory input, does not equal or is not the same as hearing loss. Some forms of auditory deafferentation cannot be discovered by audiometry. So you can have a perfectly normal audiometry, but still have a lack of sensory input. And one of the ways that could be is because the tuning curves of activation overlap. So you can have a small lesion in the cochlea, and because the tuning curves overlap, you won't even notice it on audiometry. This has been shown in humans and in animals, where you can cut part of the auditory nerve and still have normal auditory function as measured behaviorally. But that does not mean that the brain does not sense there is a lack of input and will respond to that lack of input by generating tinnitus. In general, the tinnitus covers the area of hearing loss. So if you have a hearing loss, a hearing dip, let's say at 4,000 hertz, in general, the sound that the person will perceive is around 4,000 hertz, so it covers the area of the hearing loss. But tinnitus is not just an ear problem, because it's a lack of sensory input. Just like if you have an amputation in your hand, your brain will respond to this lack of input by generating a phantom hand. The brain will generate a phantom sound. And ideally, you try to look for a cause. So initially, when somebody presents, you want to look for a cause for tinnitus. And there is multiple causes, predominantly for pulsatile tinnitus. And in general, if somebody comes with a pulsatile tinnitus, which can be either heartbeat synchronous or respiration synchronous, in about 85% of the times, you should be able to find a cause, whereas in non-pulsatile tinnitus, it's less easy to find a cause. And if you cannot find a cause, then you can still try symptomatic treatment. So if somebody presents to you in the clinic, how do you want to find a possible cause? Well, usually you look for associated symptoms that might help to distinguish the causes. For example, if you have tinnitus with vertigo, and there are short paroxysms, short bouts of tinnitus, and short bouts of vertigo associated with hemifacial spasm, which is twitching in the eye or at the mouth, associated with geniculate neuralgia, which is a short-lasting stabbing feeling in the ear, then the most common cause is a macrovascular compression, where you have a blood vessel that impinges on the auditory vestibular nerve. Now, if you have tinnitus vertigo, but you also hear yourself, and you have a Tullius phenomenon, which means that if you hear sound, you become dizzy, then that is mostly associated with a canal dehiscence, so where one of the semicircular canals which are involved in the equilibrium system, where the bony covering is lost. If the episodes of vertigo are longer lasting, instead of seconds to maybe minutes, hours, and they have an aura, so they have a kind of predictive kind of feeling, then it's more likely to be Meniere's disease. So just the fact that there is tinnitus associated with vertigo, you can still split it up in different forms of tinnitus. If tinnitus is associated with headache, which could be unilateral and throbbing, then it can be migraine, which is often associated with tinnitus. Now, if the headache is occipital and worsening when you cough or sneeze or bend over to put your shoes on, for example, then it is mostly related to an increase in intracranial pressure. And if that is, for example, associated with limb weakness or numbness, or a feeling that you can't, that part of your arms or legs are feeling colder or warmer, if you have hiccups or other dysphagia or dysphasia, then you could have a Chiari syndrome because it's tinnitus associated with headache and other symptoms. Now, if you have similar symptoms as in the microvascular compression, but associated with headache, then it might be related to an arachnoid cyst or a tumor that compresses on a nerve. So just depending on the clinical picture, you can already try to see which might be the reason why somebody has tinnitus. Now, what is the pathophysiology of the tinnitus? Well, from a conceptual point of view, you've got different pathways that bring auditory information from the cochlea to the auditory cortex. There is one pathway that just brings the auditory information to the cortex, and that's the discriminatory aspect. It will say what frequency do you hear, where do you hear it, how loud do you hear it, etc. And then there is a medial pathway which has not been well described, which goes to the insula and to the anterior cingulate, other parts of the brain that are common to all sensory systems. So it's the same pathway that is probably involved in pain and this encodes more the affective component of the pain, the distress that's associated to the tinnitus, and also it encodes the attention or the focus that somebody has to the tinnitus. Now, these two different pathways bring information to the brain, just like in pain, the information is brought from the periphery to the brain. And then there is a kind of a noise cancelling mechanism which starts from a different part of the signet, the trigeminal and rostral, and that goes to the tactile longitudinal column, and that actually suppresses further input of pain. So on the one hand, you've got a kind of an accelerator, and on the other hand, you've got a brake for more input. And most likely, it's the balance between the two. So you can either have a deficient noise cancelling mechanism or an increased or hyperactive ascending pathway that can result in hyperactivity, which is then associated with the percept of tinnitus. Now, tinnitus in itself can be perceived as a pure tone, as a noise-like phenomenon. Can be multiple tones. It can have mood changes. It can cause depression. It can decrease cognition, concentration problems, memory problems, and it can cause distress. And distress is different from mood in the sense that distress is more related to your autonomic nervous system. It's more related to an anxiety-like feeling, whereas mood is different. Now, but the patient perceives the tinnitus as a combination of all of these together, as one unified percept. And so you can try to then disentangle all these different aspects of the tinnitus by doing different imaging techniques. Here, these are all EEGs, where you try to find which areas in the brain are more active, associated with each of these characteristics. And this has come up, this has resulted in the idea that actually, from a brain point of view, that tinnitus, the unified percept, is actually a grouping of all different networks that interact at certain areas. But all these different networks can be separated. And most likely, although it's still hypothetical, all these networks run at a different frequency, a little bit like a radio system where you can broadcast at different frequencies, and if you tune in on a certain frequency, on a certain carrier wave, you have a certain clinical emergence that comes from it. And these different networks, they all communicate most likely at discrete frequencies to each other. Just like in a radio system, you have to go on a specific frequency to get the content of what is being transmitted. And in the brain, it's probably likely that it occurs at the same thing. So from a practical point of view, if you have tinnitus and you're not bothered by it, what you have is you can have different modules in your brain, and when you're not distressed, all these modules kind of work separately. Now, when you begin to have a little bit distress, then the auditory networks, which are colored here in blue, the auditory modules are connected, and the distress modules, the ones in purple, are connected, but the two are not interconnected yet. Whereas if you develop tinnitus, this real tinnitus distress, where the sounds itself becomes bothersome, that's when you develop a connection between the loudness brain networks and the distress networks. And when you get very distressed, then the frequency of information transmission between the two just seems to increase. So in other words, tinnitus distress is probably two separable networks. When they start firing together, then they're perceived as unified percepts. So theoretically, if you can cut it, you will still have the tinnitus, but it won't be distressing anymore. And where this is exactly located is between between the subgenual anterior signet and the parahippocampal area. In itself, that's not that important, but what is important is that the parahippocampal area is known as an area that encodes or processes anything which is contextual, so all contextual information that pulls actually the tinnitus from memory, that's the hypothesis, and links it to the autonomic nervous system, which will then cause your distress-like feeling, because your sympathetic or parasympathetic activity will change. So basically these connections from a brain point of view are very logical. So how can we use this information for treatment? Well, first of all, it is important to know that from a clinical point of view, some people are more difficult to treat than others. People who have tinnitus for a very long time. So we know, for example, that if you have somebody with a microvascular compression, what I've explained earlier on, if they have a blood vessel that impinges on the nerve, that the longer they have it, the more difficult it becomes, even after surgery, for the tinnitus to go away, which might seem very logical, because if the longer the blood vessel taps on the auditory nerve, the more damage you get, and then you can remove the blood vessel, but the damage is done, and so it becomes more difficult to treat. But you see the same thing with magnetic stimulation. If you do transcranial magnetic stimulation, that the longer it exists, the less beneficial the results seem to be. Tinnitus is completely non-modulated. In many or in most patients, tinnitus is modulated, for example, stress or fatigue, or loudness or noise in the environment. And some patients say, well, my tinnitus is always exactly the same, whether I'm tired, whether I'm stressed, whether I'm in an environment, where there is lots of noise, it's always the same. This is a more difficult group to treat. Musicians are also very difficult to treat, because for them, any sound is salient, and their focus on sound is more important than for many other people. Of course, people with OCD, obsessive compulsive disorder, can have a problem when you treat them. So for example, you treat them and the sound loudness goes from 8 out of 10 to 3 out of 10. Well, for somebody with OCD, they can focus as much on the 3 as they were focusing before on the 8, even though from a practical point of view, we said, well, it should be better, but the problem is not the loudness, it's the focus on the tinnitus. People who are control freaks, often very, very wealthy businessmen, when I'm in Dallas, people who tend to have everything under control in their lives except for their tinnitus have a hard time. You have a hard time in treating those patients, and of course also people who are completely psychologically decompensated. So how do you go? Well, as mentioned earlier on, you start with the case history in order to see if you can try and find a cause. Then you do the assessment, as mentioned before. You give some questionnaires to see whether the tinnitus really has an impact on the person who has the tinnitus. You do a clinical examination. Of course, you don't want to treat somebody with a brain implant if it's just some wax in the ear that's causing the tinnitus. And in pulsatile tinnitus, of course, you also do auscultations, and you do an audiological examination, as I've mentioned before. And then you can basically start by saying, well, is the tinnitus pulsatile, or is it tinnitus pulsatile or non-pulsatile? And then you can ask the guiding questions, as I mentioned before, that might try to help you find a cause. And if you don't find a cause, then you go to symptomatic treatment. So what works for tinnitus? What do we know? What can help tinnitus? Well, most commonly now we use what is called evidence-based medicine, and for tinnitus there's no evidence that anything works. So basically here I could stop giving my presentation, but there is something which is very important. It's not because it's not proven that it doesn't work. It means that sometimes you have a subgroup where a treatment might be working perfectly well, but if you look at it in the total group and you mix all the subgroups of tinnitus together, then statistically you won't find anything, even though for a subgroup it really works very well. For example, there is a form of typewriter tinnitus, which is where you have this microvascular compression that responds perfectly well to carbamazepine. The tinnitus disappears if it's the correct diagnosis. Now, if you give carbamazepine to anybody else with tinnitus, it won't work. So if you do a study and you try carbamazepine in 100 patients, statistically it won't work. But for the subgroup, it will work very well. So it's not because it's not proven that it doesn't work. Or it can be tested, but the study was poorly performed. And that's why the study doesn't show anything. So it's not because something has no proof yet that it works, that it means that it can't do anything. And there is a difference between statistical significance and clinical relevance. You can have a statistical significant study where you improve, if you have a huge amount of patients, and you do a study and you say, well, treatment X works, but it reduces the tinnitus on a loudness scale from 8 to 7.6. Well, it might be statistically significant, but it's clinically completely irrelevant. And you can have clinically relevant data that are statistically not significant. As I mentioned, you can have a small subgroup that really responds very well with a clinical relevance, but if depending on the study, it might not be statistically significant. So that just means how good it works. So what treatments are there? Well, tinnitus miracle cures don't exist. Whatever they might say on the internet, these miracle cures don't exist, unfortunately. There is a certain amount of different kinds of treatments that you can try and attempt to if you're a tinnitus patient, to undergo, or as a health provider to give. Now, on average, if you have a large tinnitus clinic, I think it's fair to say that the success rate of every of these treatments is not higher than 20 to 30%, which means that, like in a headache, if you have a patient with a headache, sometimes you might have to try 3, 4, 5, 6 different painkillers or different kinds of medication before you find something that treats the headache. Well, for tinnitus, it's exactly the same. Unfortunately, it's still trial and error. There is no clear biomarkers yet. That show you, well, for this kind of tinnitus, this will work. So unfortunately, in general, it's trial and error with a low individual success rate. But that doesn't mean that you should not do it, because from a practical point of view, as a patient, and the patients in general, they don't care. They want to be treated. Whether the success rate is 20% or 30% is still better than somebody who tells you, well, you have to learn to live with it. But you might have to undergo multiple different trials of treatment before you find something that works for the individual patient. So the concept is you treat the cause if it can be found. So for example, if we go to non-pulsatile tinnitus, you can have an acoustic neuroma that causes tinnitus. You have to know that depending on the size and depending on the treatment, the tinnitus might persist after the surgery. If the tinnitus is not bothersome before, then after the surgery, the tinnitus will not be bothersome. If it is bothersome before, then it might disappear, but if it does not disappear, it will be even more bothersome after the surgery. You might have cysts that deviate the auditory nerve, that if you treat, that can get benefit. If you have Meniere's disease, you can cut the vestibular nerve or the cochlear nerve, and whether you cut the vestibular nerve or the cochlear nerve, the results are the same with regards for the tinnitus. You can have small lesions close to the auditory cortex that if you remove, that can remove the tinnitus. You can have a Chiari syndrome where you have part of your cerebellum that sinks through your foramen magnum that can give two different kinds of tinnitus, pulsatile and non-pulsatile tinnitus, that usually respond to the surgery. You can have microvascular compressions, as I mentioned earlier on. In pulsatile tinnitus, you have more causes. That you can find in order to treat. The most common cause, which is actually not very well known, is benign intracranial hypertension, where actually is just an increase in pressure in the brain that is transmitted possibly via the cochlear aqueduct to the cochlea, where you have an increased pressure in the cochlea, a little bit like Meniere's disease. That can be treated just by putting, first by giving some furosemide, or by inserting a shunt that drains the fluid to the abdomen or to the heart, and thereby decreases the pressure in the brain. Apart from From that, as I mentioned, Chiari syndrome can give pulsatile tinnitus. You can have an abnormal blood vessel, like a high jugular bulb, which drains the blood from the head to the heart. And if it comes too high, too close to the cochlea and auditory nerve, that can be perceived as a pulsatile tinnitus. You can have fistulas which go into the mastoid, and the mastoid then acts like a kind of resonance chamber that you will hear as a pulsatile tinnitus. You can have stenosis in the intracranial part of the carotid artery, which supplies the blood to the brain. And if this is narrowed, then you will get a turbulence, which you will hear as a pulsatile tinnitus, and which can be treated by inserting a stent, just like they do for aneurysms in your brain or for stenosis in your heart. You can have a glomus tumor, which is a very vascularized but benign tumor that can cause pulsatile tinnitus. And then if you embolize it, then, so this is all abnormal blood vessels. If you embolize it, then the pulsatile tinnitus is gone. And depending on the size, you might not have to do anything else because they're extremely slow growing. So you might just leave the lesion there if it doesn't cause any other problem, and embolize it to get rid of the troublesome tinnitus. Here you have a vascular lesion in the mastoid, which you will perceive as tinnitus, or a vascular lesion in the clivus before and after surgery, which can remove. So the pulsations of the abnormal blood vessels, even though they're far away from the ear, might be perceived as pulsatile tinnitus. You can even have cutaneous or subcutaneous abnormal blood vessels that you will pick up as pulsatile tinnitus. You can have abnormal connections between arteries and veins that present as pulsatile tinnitus, or even just in your neck, a tortuous blood vessel. So if your carotid artery in your neck makes a twist, it can cause turbulence, which you can perceive, and then by trying to straighten it surgically, you can improve the tinnitus. Or you can have a loop inside the acoustic meatus, which can cause turbulence there, which can be treated also by inserting Teflon, a kind of isolation layer in between the cochlea and the vascular loop. Or you can even have a blood vessel that impinges on the cochlear aqueduct, where you can put Teflon as well. So there is a lot more treatments for pulsatile tinnitus than for non-pulsatile. And for pulsatile tinnitus, where you hear your heartbeat or your respiration, it's definitely worthwhile, if it's bothersome, to have it checked. Now, if you don't find a cause, then the first approach is usually counseling, which can be either cognitive behavioral therapy or TRT. Basically, tinnitus retraining therapy is a combination of explaining how tinnitus develops from a conditioning point of view associated with white noise. Basically, it's an attempt to tell that the tinnitus is not dangerous, and to habituate to the sound by masking it partially with white noise. The background idea is that this specific sound that you hear activates a fight and flight response, and that if you can mask it, that the new sound that you will hear, if you hear that and you develop it, basically because it's brought into your ear by a masker, if you develop it on the moment that you're not in a fight and flight response, that it will actually reduce the stress associated to the tinnitus. So, in fact, the tinnitus retraining therapy improves the distress associated to the sound, but not the sound itself. So the sound is basically replaced by a masking sound. And it seems to be better to combine masking with this explanation than just presenting masking by itself. Cognitive behavioral therapy does the same thing. It improves the distress, the affective component of the sound, but not the sound itself. And of course, if you do it in a combination and in a structured way, the results seem to be even better. Now, what about hearing aids or noise generators? So the idea is that as tinnitus depends on a lack of auditory input, if we increase the auditory input, that you can then suppress the brain's response to generate a tinnitus by adding either passive amplification, which are hearing aids, and of course the problem is that the hearing aids actually only work when there is environmental sound, because there is no environmental sound, there's not a lot to amplify, and then you'll be in the same thing. And therefore you might in quiet periods actually use active amplification, which could be a noise generator or a masking device or other sound therapies. Now, clinically, hearing aids can benefit patients with chronic tinnitus. Even though there is no evidence at a meta-analytic level, which means if you look at all the studies together and then say, well, do hearing aids work or not? They don't for the whole group. But as I mentioned, in about 20% of the patients, they will give relief, but in 40% of the patients, they will give no relief whatsoever, but in about 20%, they will give marked relief. But of course, because there is more people where it doesn't help than there is where it helps, then on the total group, unfortunately, it doesn't seem to help. But that doesn't mean that it's worthless to prescribe hearing aids, because they can benefit even if it's just a small subgroup. If you add masking to the hearing aids, and the masking you add to create another sound which is not disturbing, or to add another sound when it's quiet and the hearing aid doesn't do a lot, then it seems to be more beneficial than one or the other. But again, if you look at all the studies together, statistically speaking, there is no benefit from hearing aids and masking. But it's always the same thing. There is a subgroup who does seem to benefit from it. There is some modern forms of active hearing aid, which is, for example, neuromonics. And neuromonics actually tries to, even though nobody really knows what it exactly does, it is suggested that it increases the sound or the music that is at the level of the hearing loss. So the concept is the tinnitus is usually covering the area of hearing loss. If we just accentuate the music at the level of the hearing loss, it should give some benefit. On average, 50% of the patients think it's worth the cost that they paid for the device, and 50% improve distress, but not sound. So basically, most of the treatment, except for the hearing aids, have actually a result on how it affects the distress rather than the sound itself. There was an idea of using phase out, which is a kind of an anti-sound. The idea was if you hear a certain sound and you give an anti-sound, a little bit like the noise cancelling earphones that you can use in an airplane, that would work. We tried it and it didn't work. Actually, it worsened the tinnitus. The frequent, or you can theoretically, we know that if you have a hearing loss and you fill this up, theoretically, you should get rid of the tinnitus, because the brain gets all the input and it won't make the tinnitus by itself. So we set out to do an iPod study where, if this is the audiogram, so you've got normal hearing and then a hearing dip, that if we fill it up, then the brain should not create tinnitus anymore. Or you could even do better. We thought you can over-accentuate, you can overcompensate the gap, and thereby the brain would definitely not make the brain. That was the idea. So the way we did it, we had some iPods. We adjusted the music to the audiometry. For example, if you have a hearing loss here, this is the music spectrum. You just accentuate it, or you create a little dip before and you make it even stronger. So what happened? Well, the compensated music was not better than doing nothing. Then overcompensated music actually made it worse. And this is because we've forgotten one thing, that what we were looking at was trying to follow the pathophysiology, but what we forgot is that tinnitus is actually, or in the brain of somebody who has tinnitus, who's suffering from it, tinnitus has an abnormal salience, has an abnormal value attached to it. Normally, everything which is constant is disregarded by our brain. We don't feel our clothes because it's always the same stimulus. And the brain says, well, there's no new information and constantly feeling our clothes, so we suppress it. Now, the fact that people constantly hear their tinnitus, by definition, means that there is a paradoxical salience. So if you're going to increase the sound, which has already a pathological salience to it, then you might actually worsen. And so it's probably a salience problem rather than a physiological filling up. Now what we found is that when we overcompensated the music, actually the gamma band activity in the auditory cortex, which we know, so it's high frequency overactivity in the auditory cortex, went up, and the area in the cingulate, which is important for salience, actually was up as well. So we think that actually the problem was, even though theoretical concept was good, that salience overrides physiology. So if that doesn't work, if adding the missing information doesn't work, well, maybe we should do the opposite. Try to decrease the salience of the tinnitus by cutting out some of the tinnitus completely. And this is a study that was done by Pantef, where if this is the tinnitus frequency, actually they notched the music so that it was completely cut out, so that there was no salience whatsoever. And what they found is actually that there was a benefit. But you have to be careful with these results, because if you see the improvement that in the ones who did not get this treatment, actually they worsened a little bit. So the result might actually be because the control group worsened rather than that the other ones really improved. So, and then you can do, well, if even, just imagine that the concept works, then we might have to enforce this by doing the same thing, but you add vagal nerve stimulation to it. And this has been developed here in Mike Kilgard's group, where you present tones, except for the tinnitus tones, or the tones that the patients hear, and simultaneously you give a vagus stimulation. And the idea goes back to the physiology, where if you have normally in the cortex, every frequency arrives at a specific structured order in a nicely ordered way at different frequencies, arrive at places one next to the other. When you develop tinnitus, this whole orderly system becomes disorganized, but you know that if you present an auditory stimulus at a specific frequency and you give simultaneously a stimulation of the vagal nerve, that you can strengthen that frequency at least at the level of the cortex, which means that, as we know that in tinnitus there is a problem of this reorganization, that with this theory, if you can make a system that does it, that it should work. And indeed, in rats, it works in 100% of rats that can abolish the percept of tinnitus. And so what Mike did, and correct me if I'm wrong, so you present a tone and simultaneously you present a stimulation. If you only present a tone, then the tinnitus remained. If you only present the stimulation, electrical stimulation, the tinnitus remained. But if you pair them together, then the tinnitus gets improved. So it's critically important that the tone presentation and the vagal stimulation becomes associated. So how do you do that? Well, you implant an electrode on the vagus nerve, which you can see here, and this is then tunneled, comes out, the electrode comes out of the abdomen, is connected to a computer, and you have earphones on. These earphones then basically activate tones, except for the tinnitus tones. So it's a little bit like Pantef concept, but a strengthened version of it, and simultaneously you get a stimulation electrically in the vagus nerve and a tone. And when we did that in humans, what we saw is there were actually two groups. One group that improved and one group that did not improve. And the difference, we think, was that this group, first of all, there were the patients who were worse from the start, and they were all on medication that interfered with the mechanism of release of acetylcholine and noradrenaline, which is critically important in order to get this reorganization. And so the ones that did respond did not take the medication. So which means that sometimes that if you want this to work, that the patients should probably be medication-free. So, and if that works for a group but not for everybody, then you can still try to treat synchrony. Now there is a hypothesis that you can do that with coordinated reset auditory stimulation. The idea sounds very good in that normally in the auditory cortex you've got all these cells in a structured way that process information, but they're all active in a little bit of a chaotic way. And if they become hypersynchronized, then they behave like a choir, and the message will be a lot stronger, and you will hear it as a sound. So the synchrony might be related to the tinnitus. And the idea is that if you present sounds by a kind of a hearing aid that has a stimulator in it, that you can desynchronize these activities. So the concept is that if you hear a tone at 6,000 hertz, then you give sounds surrounding these 6,000 hertz to desynchronize the 6,000 hertz, which is somewhat counterintuitive because theoretically you would have to stimulate within this pool in order to do that. So there is a small discrepancy between the theory and practice, but they have shown that, again, a subgroup of patients seems to respond to it, and this subgroup who responds, their brain activity normalizes as well, whereas in the subgroup of patients who do not respond, there is no normalization of abnormal activity. So these are their data. So what you see in color is basically what is abnormal, that's pathological activity, and then the group who responds well is the one on the last line and over here as well, and the group that does not respond does not have a difference between the pre-treatment. And not only activity but also connectivity, so the influence of one area on the other seems to normalize after the treatment, but only in the group who responds to the treatment. So just imagine you've tried, you didn't find a cause, you've tried hearing aids, you've tried masking, it doesn't help. What else can you do? Well, you can try some medications. Now medications, there's lots of medications that have been tried, and there is no medication that works at a global level. But individually, some medications are very beneficial. Like I mentioned, the carbamazepine and the typewriter tinnitus. Now, a combination that I often use is a combination of dianxite and rivotril. Basically, it's a dirty cocktail. It's a cocktail of mellitrosene, a tricyclic antidepressant. It's an antipsychotic. It's a dopamine-influencing drug, and it is a clonazepam, which is a benzodiazepine. Now, say, why would you try to use a cocktail instead of one pure drug? Well, probably because in a tinnitus brain, there's not just one neurotransmitter that's non-functional. We know from other diseases like depression, where they say, well, depression is simple, it's a lack of serotonin, so you increase the serotonin and they're cured, that it doesn't work. Now, if one neurotransmitter changes, it will automatically alter other neurotransmitters as well. Or if you look at it from a network point of view, if you have a network and you block it at one spot, basically what will happen is the information in your brain will just take a route around it and the tinnitus will come back. Now, if you can stop it at multiple areas, then you've got less chance that the system can adjust to it and that the tinnitus comes back. So why do we use this cocktail? Well, flupentixol, I think, is the most important part. This is a very old drug. It's more than 40 years old, and it's one of the only drugs that blocks dopamine D1 receptors. There's 5 receptors. Now that's not that important, except that's what's happening is normally when you're exposed to the environment, you get a lot of inputs simultaneously. The dopamine D2 receptors are the most sensitive, so they will respond first, and they will basically they will activate for every stimulus that comes in. So you pick up whatever is happening in the environment. And then if the stimulus is strong enough, your dopamine D1 receptors become activated, and they only zoom in or focus on the strongest stimulus. So the concept is, because your brain focuses on the tinnitus, that's why you hear it, because normally it should be like your clothes, it should be disregarded. With a dopamine D1 blocker, you should be able to defocus the brain from the input, which also means that there is a very simple question to know whether this should work or not. If you ask a patient, well, how much of the time, what percentage of the time is the tinnitus dominantly present? In other words, are you in this dopamine D1 hyperactivity state? Well, if they say 5%, you can try, the medication won't work. If they say 85%, then it might work, because you're trying to cut exactly this hyper-focusing on the sound. And so when we did the first study, trying to be scientific, you say, well, we take the first 50 patients that come in, they all get the medication, and it did something, but it didn't do a lot, which makes sense, because if you don't ask the specific question, you won't get the right subgroup. And if you get the right subgroup, then the medication might work. So there is other medications that have been tried, like amisulpride and melatonin. Basically, you also try to work on your dopamine system. Cyclobenzaprine, which is a muscle relaxant, which might benefit patients predominantly who have tinnitus that is modified by neck movements or by somatosensory interactions. Naltrexone, which is a drug that works on your opioid system. Alprazolam, which is simultaneous to the clonazepam. And why would you use alprazolam or clonazepam? Well, these drugs actually increase your GABA-A, and we know that in tinnitus there is a GABA-A is basically a brake. So if you have hyperactivity, it's either too much acceleration or not enough braking. And we know in tinnitus that in the cochlear nucleus there is not enough braking going on. So if you can increase the brake by adding GABA-A, which you do by clonazepam or alprazolam, then you might get some benefit. And actually, if you combine them with this dopamine influence, like I said, you try to modulate different systems simultaneously, which might be better in trying to get control of the sound. And acamprosate is actually a drug that is used for people who want to stop with alcohol addiction in order to prevent withdrawal symptoms. And that seems to be beneficial for tinnitus as well in a certain subgroup of patients, but definitely not in all. So basically, what does it mean? It means that you might have to try different medications, just like you do in headaches, in order to find something that gives benefit. A realistic improvement that you can get with these medications, because you have to give them in low doses so you don't get side effects, is that you get an improvement of in between 2 and 4 points on a numeric rating scale from 1 to 10. So if they score, let's say, 8 out of 10, you can drop it to 4, but probably not below that level. So if the medication doesn't work either, then you can go to neuromodulation. And neuromodulation, the idea is that whatever we know about the changes in the brain that are associated with the tinnitus, that we try to normalize or we try to influence them. You can do that non-surgically or you can do that surgically. And non-surgical modulation is TMS, or transcranial magnetic stimulation, so you apply magnetic pulses to the brain. Transcranial electrical stimulation, and there's different versions of that. You can use direct current stimulation, which is basically the car battery with an anode and a cathode. You can use alternating current stimulation, random noise stimulation, or variations of these stimulations. Or you can use neurofeedback, You can use electroconvulsive therapy, and maybe acupuncture also falls under this non-surgical neuromodulation. Or you can go to surgical modulation, where you can implant electrodes on different parts of the brain. So the most commonly used non-surgical neuromodulation techniques are TENS, where you modulate the C2 nerve, and I'll explain why. In order to try and treat the tinnitus, you can use a magnetic stimulation targeting the auditory cortex, the frontal cortex, or even the cingulate. You can use direct current stimulation with an anode and a cathode, where the current goes from one pole to the other pole. 50% goes to the skin, but also 50% goes to the brain. And then you can modulate brain areas, because whatever is under the anode, you will increase activity and excitability, and if it's under the cathode, you will decrease excitability and activity. And you've got alternating current stimulation, which is more trying to drive the normal activity of the brain to a certain frequency, or random noise, where we don't really know very well what it does, but it's hypothesized that it can desynchronize ongoing activity. And then, of course, ECT can be tried, although that there is very, very little literature on ECT. And neurofeedback can be tried, where basically you record brain activity, the patient looks at the screen, and you say, well, this is the pathological activity. We want to normalize this, and the way you do it, that is, because the brain constantly changes its activity, whenever it's within the good range, you give a positive reward, which could be a green light. Whenever it's pathological activity, you give a red light. Or you can have a movie that continues when it's good activity, or stops when it's not good activity. So this is neurofeedback. Now, what all of these techniques have in common is basically that they change functional and effective connectivity. So basically, what they all have in common is that they change the connections between the brain, between different brain areas. And we don't know for many of these techniques what they actually do. For example, for TMS, it has been suggested that they change synchronization, but what it does is whenever you give a pulse, you get an action potential, which is different from all the other techniques. With TDCS, TACS, TRNS, implants, ECT, and neurofeedback, you don't get action potentials when you stimulate. With direct current stimulation, we know that you depolarize and hyperpolarize depending on where the anode and the cathode is. With alternating current stimulation, it is suggested that it entrains specific frequencies that you want to modulate. TRNS, as I mentioned, we don't know. It is hypothesized that it desynchronizes activity. Implants work predominantly by creating virtual lesions. ECT, electroconvulsive therapy, is a kind of global reset through an epileptic seizure that you induce, and the hope is that when the brain circuits reset, that they will reset in a non-tinnitus way. And neurofeedback is where you try to train the oscillations. There is variations of that. There is different kinds of neuromodulation techniques, but the most important thing, which might be actually the one that changes the clinic, is that it changes the connection between the auditory cortex, parahippocampal area, anterior cingulate, insula, those areas of the brain that are involved in tinnitus generation. Now, how do you know? Well, we once did a study where there was patients who received all three. So they received magnetic stimulation, direct current stimulation, and TENS stimulation in the neck. And based on the results of these studies, we hypothesized actually that magnetic stimulation has a double effect. First of all, it has a direct effect on the auditory cortex if you target the auditory cortex, but it also modulates the superficial nerves. And why do we know that? Because the TENS only stimulates the superficial nerves, and TENS stimulation can, even though it's not a lot, predict whether TDCS or whether TMS will work. And so the same for direct current stimulation. It has a double effect. It modulates your auditory cortex indirectly, even if you put the electrodes on the frontal cortex, and it activates your trigeminal nerve, and both your trigeminal nerve and your C2 nerve have direct connections to the auditory pathways and can be inhibitory on the auditory pathways. So the effect that you have is directly on the cortex and indirectly on compensation mechanisms. So neuromodulation has changed in recent times. The old idea was very simple. The auditory cortex is the final common pathway of tinnitus. So if we suppress the hyperactivity in the auditory cortex, theoretically we should be able to cure everybody. And there was some arguments because there was changes on PET scan, on EEG, on magnetoencephalography, on fMRI, which all pointed at the involvement of the auditory cortex. So it was the most logical target to try and suppress. And if the treatment doesn't work, well, maybe it's because we're not communicating in the right way with the cortex. We're talking to the cortex by electrical or magnetic stimulation in a language it doesn't understand. So if we change the language, if we change the stimulation design, then maybe it will work. And indeed, in some of the patients who did not respond to the classical stimulation, one which changed to another stimulation design, such as burst stimulation, we could rescue some of those people who did not respond. So the idea was, it's easy, target the final common pathway, the auditory cortex, and the problem is solved. Now, unfortunately, even for this, at a meta-analytic level, so when you could look at all the studies that have been done for magnetic stimulation of the auditory cortex, it doesn't work. If you look at the same thing for direct current stimulation, it seems to do a little bit, but not a lot, because if you can only reduce the intensity by 13%, that's not clinically beneficial enough to do anything as a routine treatment. So what we then did is we compared direct current stimulation to alternating current stimulation to random noise stimulation, see what the different techniques do on the auditory cortex. And what you could see is indeed that direct current and alternating current stimulation doesn't do a lot, but that we only had a beneficial effect both on loudness and on the amount of distress with random noise stimulation. So random noise stimulation seemed to be more beneficial for one or another reason if you apply this kind of current. And if you look more closely, actually what you see is that it benefits if you use low frequency random noise and high frequency random noise. Low frequency random noise means that you use frequencies between 0.1 Hertz and 100 Hertz randomly, and high frequency means that you use frequencies between 100 and 640 Hertz randomly. And interestingly, if you combine them, nothing happens. So low frequency seems to do something and high frequency seems to do something, but the combination doesn't do anything, which again exemplifies that if you do studies, and you would do a study on random noise stimulation for tinnitus, and you would use the normal machine settings, which is just use everything that's there from 0.1 to 640, you won't get a result. But if you go to to different stimulation design or sub-stimulation design, then you do see some benefit. So, and recently we also looked at neurofeedback because we know that the posterior part of the cingulate is involved in cognition and also in distress associated with tinnitus. So some patients we targeted this posterior part of the cingulates, and some we targeted another area, and then some patients were on a waiting list. And what you see is that if you compare before and after, that it changed something only when you target the posterior cingulate with neurofeedback, that you had a clinical effect on distress, and then it makes sense that the patients with high distress, that they have a better effect than the patients with low distress. And that some of the patients moved from that at the end of the neurofeedback, there was less people in the high distress group and more people in the lower distress groups than before. So it seems to do something on distress, but not on loudness. So even though we were treating the patients, basically the tinnitus was not bothersome, not as bothersome, but the loudness did not change, just like what we've seen in cognitive behavioral treatment, in TRT, and in some of the medication. So then the question is, what can we still do, or are we running out of ideas? Well, similar like the dirty drug, where you try to interfere with multiple sites in a network, then you can do that with stimulation as well. So the concept is, if you're on a highway and the highway is blocked, everybody will take the route around it. So if you could also block the route around it, then you have to go even further. So the more routes you can block, the less chance you have of getting where you want to get in time. So the concept is, just like in a dirty drug, why not call it dirty stimulation, where you use multiple targets in order to have an effect. Or you can use another target. You can say, well, the auditory cortex works, but not very well. Let's try other targets. For example, the frontal cortex, or the cingulate cortex, or the parietal area. So, and how do you do that? Well, you look at imaging. So you look at EEG activity in the specific individual patient, where it is abnormal in comparison to controls, or in fMRI, where the activity is abnormal. You use non-invasive stimulation, for example, transcranial magnetic stimulation, targeting this specific area that is abnormal in this specific patient. And if you get a benefit, you do it repetitively. If it doesn't last long enough, then you can implant, for example, an electrode. So you can look for another spot. Or, like they suggested in Germany, you can target multiple spots simultaneously, so the network doesn't have a chance to reset. So when we implanted the first electrodes on the auditory cortex, what we saw is that if the patient had pure tone tinnitus, they responded well. If they had a noise-like tinnitus, they did not respond at all. And if they had a combination, they responded where the pure tone went away, but not the noise-like component. And so then we developed this burst stimulation design, and what we saw is that the initial study where we implanted 43 patients with electrodes on the auditory cortex, and we stimulated them in a classical way, actually 2 out of 3 did not respond. The inclusion criteria were that they responded to magnetic stimulation twice in a placebo-controlled way, but they did not respond to the implant, whereas only 1 out of 3 did respond. So when we then switched them to burst mode, actually half of them could be rescued. So half of the non-responders could be rescued, and the ones that responded could be further improved. That's very good, because you can help more people with it, but you still have a fair amount of non-responders. And then the question is, why do they not respond? We know we're at auditory cortex, so we thought, well, that's the final common pathway. They should respond. So what we then did is we looked at people who did respond and compared them to people who did not respond, and we subtracted the activity to see the difference. And what we expected to see was that there was a difference in the auditory cortex, because that's where we put the electrode. Now, to our surprise, the auditory cortex, there was no difference whatsoever. But there was a difference in the parahippocampal area here, which is involved in auditory memory. It's like an entry and exit gate to memory. So you pull auditory memory from the hippocampus through the parahippocampus, or you put it in to the hippocampus via the parahippocampus. But that's strange, because the electrode is there, and whether or not you will respond to the auditory cortex implant depends on activity deep in the brain. So the way to look at that then is to look at functional connectivity. And this is how the brain communicates. So these red lines just means that there is communication between the auditory cortex and the parahippocampus. And those who responded to the treatment of the auditory cortex were those who had good connections. Those who did not have connections did not respond. And then it makes sense. If you stimulate there, but the problem is there, and if you've got a good connection, well, the information that you put in there goes there, and you've got a response. So basically, probably with the wrong theory, we had a beneficial effect, but we didn't know. A little bit like Thales of Mileto predicted the solar eclipse in 580 something before Christ, with the wrong model, with the geocentric model. We used the wrong model, but it had the right prediction. And we seemed to have some good results, even though probably the model might have been wrong. So since then, electrodes have been implanted on the dorsolateral prefrontal cortex, to my knowledge only in 2 patients, many more, but still not a lot in the auditory cortex. There have been some results of electrodes that are implanted in the caudate, not because of tinnitus. They were implanted there because of movement, or the trajectory went through the caudate nucleus on the way to the thalamus for movement disorders, and they saw when they were going through the thalamus, caudate, and were stimulating there, that the tinnitus improved. We've put electrodes on in 2 patients on the anterior cingulate, which worked in one very well, and the other one it didn't do a lot. So the question is, well, we haven't found a cause. TRT or CBT might improve the distress. Hearing aids seem to work in about 20% of the patients, as does the noise generators. The combination might be even better. Medication work predominantly if the patients have suffered from it for a long, or if it's dominantly present during a long part of the day. And neuromodulation is unpredictable in a certain way, because we don't know exactly where to stimulate, and we'll have to go to individualized treatments, adjusting the treatment to what the patient has, which is, for example, bivagal nerve stimulation, pairing it with sounds, but specific sounds, not any sounds, sounds that are related to the hearing loss of the patient. And there's other treatments which you can find. Acupuncture, any systematic review, no evidence of efficacy. Hyperbaric oxygen therapy, meta-analysis, no evidence of benefit. Laser therapy, no efficacy longer than 3 months. So basically, where do you end up? Well, in conclusion, since a couple of years we know a lot more about the pathophysiology of tinnitus, and a lot of treatments have been tried. None of them works for everybody. There is no golden bullet that works. But for subgroups of patients, some of these treatments are actually very good. But if you look at the whole group, it won't work. But in subgroups, it will work. So from starting point, is the best way is to find a cause, and you do that predominantly by looking at associated symptom and treat it. If you can't find a cause, then giving information about what tinnitus is, how it develops, that it is not life-threatening, combining it with noise, as in TRT, might actually be beneficial for the distress. If hearing loss at the tinnitus frequency, if there is hearing loss at the tinnitus frequency, and why at the tinnitus frequency? Because that means that the tinnitus is related to the hearing loss. Then it might be worthwhile to try hearing aids and or masking, where you have 20 to 30% chance that you will have a beneficial effect. If there is no benefit, and in a high percentage of the day the tinnitus is predominantly present, interfering with concentration, sleep, memory, etc., then you might be worthwhile trying medication, and there is a couple of medications that seem to be pathophysiologically reasonable to use. And if nothing works, you can still try neuromodulation. And if neuromodulation does not work, well, then I would propose to try any of the studies that are going on in order to see if you can still get any benefit. And that was basically a summary of the possible treatments for tinnitus. I thank you for your attention.
Thank you, Dirk, for a wonderful talk.